Excellent. So welcome, and what a fantastic panel of presentations we've had today. So I've got the unenviable task of trying to bring all of this together and present what I hope will be a framework for managing opioid prescribing in primary care. I've got the help of Dr. Yasir Abbasi. He's an authority on addiction medicine and psychiatry, and we will try to work our way through this to try and map out exactly what should we be doing and how can we move forwards. The core components of this stewardship are as follows, and we'll just try and run through that in the next couple of minutes. In terms of acute presentations, I think we need to have a cultural shift in the way we approach acute pain presentations clinically and reduce the emphasis to defaulting to acute painkilling medicine and looking at a multimodal approach. And ideally limiting acute prescriptions of opiates where they're absolutely necessary. And in those instances, really to risk stratify patients who you are prescribing for. And there are a number of very good tools, and we'll provide those in the references, which just give you some indicators of what's the chance of this patient developing dependence. I think documentation is key. We need to be documenting using templates in which we've educated and shared that decision making with patients about the risk of dependence, side effects, driving precautions, the risk of addiction, and the consequences of their prescribed opiate use. I would advocate to avoid MR preparations in an acute context and just think about some scripts. We spoke earlier about language. How might you communicate this with a patient? I use script, just really signposting that this is a short-term solution and we won't be revisiting this. So that just really sets expectations. So essentially, we've got four subsets of patients. We've talked about acute pain, and then we've got the long-term opiate users, and they're divided into three groups. So the first group have been prescribed on a relatively short-term basis, maybe weeks to months. The second group would be defined as those taking higher doses of long-term prescribed opiates. They may also have co-prescribed potentiating medicine, which increases their risk, comorbidity, age, and other social factors, which increases their risk profile. And the last group of patients are those patients you suspect there are concerns around addiction and misuse. The first thing to emphasize is deprescribing is part of the patient journey, as Kerry explained so well and Asim earlier on. We need to provide holistic pain support. We aren't prescribing, we aren't advocating deprescribing to sit as a standalone measure. That needs to be in the structure of something like Rethinking Pain, or if you don't have access to those sort of services, the whole raft of community support services that are available. Mental health commonly co-occurs with pain, and addressing this is critical, particularly as patients using long-term opioids may be using this to support their mental health. Accessing social support and also screening for risk factors are key components. And from a consultation basis, continuity of care is critical. Having the same clinician developing a trusting relationship with the patient is really important to that patient journey. I've got this model which essentially summarizes our model of how we work with patients in Bradford and Craven with pain. It's a combination of theoretical changes in behavior and also trauma-informed therapy. And the reason I put this up is to show two things. If you notice, acceptance and readiness to take action are downstream on the patient journey. I'll say that again. Acceptance and taking action are downstream on the patient journey. If you are seeing a patient for the first time and they've been taking medicine for years, and you try to deprescribe at that moment in time without developing and exploring some of the other things showing in this model, you're likely to have a negative outcome. So when it comes to scheduled pain reviews, how should we approach this? I would suggest we divide the cohorts into two. We have a moderate risk cohort, which would be perhaps more amenable to deprescribing in primary care, typified by a lower dose of opiate use, maybe a single opiate use, and to engage with the patient with slow decrements, as Asim explained earlier on. And I'm going to hand over to Yasir in a moment to talk about the high-risk cohort. So these are prescribed high doses of morphine equivalent doses, often co-prescriptions, and a whole raft of risk factors for opiate overuse and potential addiction, which are more complex. So I'd just like to invite Yasir onto the call if he's, I think he's waiting in the panel.
Can you hear me all right? Okay, brilliant.
Yeah, I can hear you, Yasir, thanks.
Thank you very much. So, thank you very much. Thank you, everyone. And unfortunately, I'm not controlling the slide, so you'll keep on hearing me saying next, which can sometimes be quite irritating. So just bear with me. And can I also mention what a great kind of set of speakers and agenda. And when I heard Kerry talk about joint commissioning, my heart jumped out of my throat. Really, I've been talking about joint commissioning for the past, I don't know, 12 years, since 2012, when I first set up prescription addiction clinic at the Leeds Addiction Unit in Leeds. That's where I was a consultant when I started off my consultant career. And then I moved on to other places. But joint commissioning is really the answer. Sometimes you'll have a lot of addiction services not taking on these clients because this is prescribed addiction. Quite a lot of these services do not have this in their service specification, and they're not really funded to address this. However, the person who struggles to deal with all or struggles to navigate all the system is the client or the service you're struggling with this. So we need to go towards a joint commissioning model. Shahzad, if you just press next a few times, because this is kind of an animated slide, and we'll get to the bottom of it. So this is usually the journey. I'm not going to take a long time describing this. And can we stop there? Yeah. So you'll have patients with chronic pain, you prescribe opioids, then they're using it for more than 3 months. Ideally, chronic pain is described as pain consistently throughout the day, continuously for 3 months, and that's considered as chronic pain. And as the evidence has been discussed already, there's not a huge amount of evidence supporting use of opioids in chronic pain. And then sometimes patients develop tolerance and then hyperalgesia as well, where they become quite sensitive to the pain stimuli, and the opioids make them hyperalgesic. And then doses are increased, and eventually you realize you've gone beyond, and the people are dependent and addicted, and they become high risk. So again, Shahzad, if you press next a few times, just to see all the considerations. Yes. So these are the considerations at different points in times during your prescribing journey. Your prescribing practice should make sure you're considering these elements at every point. Is opioid the best analgesic to prescribe at that point in time? If you've got to a high opioid, should we taper it down and think of alternative analgesics? And if it is very complex and you're finding it difficult to manage, then you consider substance misuse referral. Possibly you're thinking of detoxification, or you're thinking of direct residential detox placements, but that is when you are working very closely with the substance misuse services. However, you might have, I mean, the aim of all this, and I'm so glad to look at this Rethinking Pain service. It's absolutely brilliant. I think when I was working in Merseycare in Liverpool, I presented a model which I think was very similar to what the Rethinking Pain model is like. You kind of provide a multi-modal, multidisciplinary approach to try and help people. So the aim is not to bring down opioid prescription to 0 in people who have chronic pain. The evidence isn't there, but you will have some people who will struggle with pain. You'll have some people who have chronic conditions and they have other comorbid health conditions. And there's really, to be fair, outside the opioid spectrum, there are not that many other analgesia available to use if it comes to just prescribing. So if you don't have access to educating patient around exercise, if you don't have access to CBT for pain, if you don't have access to physiotherapy, and you have to prescribe pain relief medication, then there'll be a small cohort of patients where you're prescribing opioid for chronic pain. As long as you're very closely monitoring it, you're making sure it's the least possible dose that is supposed to be prescribed, which really helps them, and there's no misuse, which means they're not using the opioids for reasons other than pain, or not refilling the prescription constantly, and the sticking to the prescribed doses, and you're constantly reviewing them. So you'll still have a cohort like that. But if you have the multimodal holistic approach and services out there, so then that's great. You kind of approach it through those elements. I still remember there's an elderly gentleman with arthritis. He used to take the full dose of codeine during the day, sometimes taking a couple of more tablets on above that. And we had to sit down and understand his lifestyle. And what we understood was he was an avid gardener, and the gardening would make his pain worse. So we then came up with a plan where we decided, well, on his smartphone, we helped him understand how to work out the the alarm and the stopwatch, and to set up alarms on his phone for every 10 minutes that he's out there gardening. And after every 10 minutes, he'll go and rest for at least half an hour, giving himself the right amount of stress to recuperate. And then we left it up to him and to how much he was using. His use from 8 tablets went down to only 4 tablets a week. So 8 tablets per day down to 4 tablets a week, because he understood his lifestyle better. He understood his pain better. And again, he still prescribed a bit of codeine, but he's not anywhere near being a risky gentleman. So these are the elements that you have to continuously think of. Sometimes you see individuals who become quite resistant to change. Resistance to change is part of human behavior for any changes. If, for example, you wanted to become more healthier and exercise, you'll find a lot of reasons not to exercise or procrastinate. That in itself is resistance to change. And then you need to work in a motivational, engaging manner to try and understand what are the triggers, what are the barriers, do a decisional balance scale with them so that they reflect and they start changing their behavior themselves. Enforced change never sustains for a long period of time. So if you go on to the next slide, which most probably is my last slide, you will have a cohort of clients with a number of presentations. Who would you want to kind of deal with because they raise concerns for you and they're high risk? So a lot of them would be on doses of morphine equivalent opioids, which are 120 milligrams or more. They'll have polypharmacy, and you would be thinking, what do I need to do first? And it's up to your risk stratification and assessment as to what medication you like to address first. If you're addressing the opioid first, then the ideal is, if they're on a number of opioid medication, for example, they're on codeine and tramadol and they're a bit of morphine or oromorph, the ideal is to amalgamate all that into one long-acting opioid medication like MST or morphine continuous. Even if it goes above more than 120 milligram of those per day, you have amalgamated and converted all the opiates you're prescribing into one tablet with a very clear plan of how you want to reduce it. Earlier on, I saw a chart of a reduction regime, and that's absolutely fine. You work on reduction regime, and you work your way towards a plan to reduce by 10 milligrams per week, 10 milligrams every 2 weeks, whatever you think is appropriate with a client. But I always say, don't get too pedantic about the regime. As long as you're reducing, and you're reducing at the right rate, it's not too uncomfortable to the client. If it comes to a point where after 2 reductions, they're feeling really uncomfortable and you have to kind of stabilize on that dose, that's fine. As long as you're not increasing back up and you're going down, the rate of reduction is not very specific. If a client is ready to reduce it but weekly, brilliant. Fortnightly, brilliant. If you need to review it on a regular basis and see what would be the right dose, then go for it and work with them. It requires more time than usual. And I do understand the pressures on primary care are immense, but you need to make sure you kind of take out extra time to kind of ensure that you're providing the right input. So yeah, converting them to long-acting opioid medication would be the best thing. Accessing substance misuse services is the million-dollar question. I think it's always good to engage with the substance misuse service, particularly after you've tried some elements yourself, for example, converting into long-acting medication, or if they're on simple codeine prescription, trying to just reduce that at a rate that you feel is appropriate, but the patient keeps on relapsing, or you're very concerned because there's a lot of polypharmacy and mental health issues. With a few clients where prescribed dependents weren't within the remit, weren't within our service specification, and we would struggle to prescribe because that would fall out of our budget remit. What we've done is we've had a nice, healthy, detailed meeting with the primary care providers. We've discussed exactly what I've discussed now in terms of reducing regime. The primary care provider felt that they could work with the reducing regime, they could do what we were advising them to do, whereas we said, well, you can refer them to us and we'll start providing some psychosocial interventions, some PSI sessions for them to understand addiction and how to work with them, gave them a set timeline of doing 6 to 12 sessions with us whilst you continue to reduce the dose. And that has worked in a number of places where we couldn't get over the barriers of how services are commissioned. But we need to have a standardized approach across the country. We need to start talking to our commissioning authorities. We need to start talking to public health, local authorities, and ICBs, and come up with a model. And I think this rethink model is really, really interesting. It'll be really nice to see how it works around and across other areas, and to see how joint commissioning could help develop more skill sets and resource and resilience within the system to be able to address this. And I think that would bring us to the end of what I have to say.